Good evening. My name is Brendan. I'm the COVID-19 lead from Adelaide PHN. I'd just firstly like to acknowledge the Kaurna peoples, who are the traditional custodians of the Adelaide region. We pay tribute to their physical and spiritual connections to the land, waters and community. And during now, as it has been throughout the time, we pay respect to them, their culture and the elders past and present. First of all, I'd like to thank Dr. Emily Kirkpatrick, the Deputy Chief Medical Officer, for facilitating, and as well as, Dr. Melanie Smith, the COVID Response Care Team, for facilitating this event tonight. And I'd also like to thank them for providing Cara Kolopelnyk, the clinical pharmacist from the COVID Care Centre from Adelaide Local Health Network. And thank you. I'm going to pass it over to you, Emily. So thanks very much. And I look forward to hearing your presentation.
Wonderful, and thank you, Brendan, for the introduction. And first of all, would like to acknowledge the land in which we're meeting here today, and for me on the Kaurna lands here in South Australia, and pay my respects to elders past, present and emerging. We've had some technical issues in SA Health today with some of our networks, so I've made the wise decision to not call in from my office, which is very rare for me. So apologies if my audio isn't as clear as I'd like it to be. So we're very pleased today that we are able to give an update of where we're sitting currently with the COVID-19 oral medications, and particularly very pleased that we can now talk through around the two medications that are available here in South Australia, Molnupiravir and Paxlovid, and the Paxlovid coming onto the PBS on the 1st of May. So we have Dr. Melanie Smith, who's our GP liaison COVID special projects, who's been leading our GP liaison team, which has now grown to 6 Mel. We have 6 GP liaisons now in total in the team, which is fabulous, all focusing on different areas, and Mel's strength being overseeing our COVID-19 response for the GP liaison team. And I also wanted to welcome Cara, and we're very pleased that Cara had agreed to present this evening as the clinical pharmacist in the COVID Care Centre at Carlin, who's been doing a phenomenal job in being able to get us all very organised and educated around what these medications mean, and of course, what do they mean for us in general practice? So before we commence, I just wanted to provide a very brief COVID update. And this was more so focused on the fact that we are still seeing quite high cases here in the state. And a reminder for GPs out in the community that if your patient does test positive for COVID-19 and they are at high risk, this is your opportunity to refer your patient in for medication to one of our COVID care centres, or through the PBS Authority Streamlined Prescription Scheme for Molnupiravir, or very soon Paxlovid. So a very, very important timely webinar that we've been able to host mid-school holidays, so that we can provide that education out to everyone in the community. Now we will be responding to questions and answers in the chat box, in the Q&A box. So please post in the Q&A rather than the chat box, and Mel and I will go through and answer those as the webinar progresses. I'm very happy to have all questions COVID related to our GP unit as well, and we'll try our best to answer those. If there's emerging themes, we can certainly come back to those at the end of today's presentation and answer those verbally out to everyone. So very big thank you from me, and I'm going to hand over first of all to Dr. Melanie Smith. Thanks, Mel.
Thanks, Emily, and hopefully you can all see my slides. And I'm just going to, oh no, it's disappeared. Let me pull that up again. Being a little bit recalcitrant.
Perfect, Mel. We can see your screen now.
Awesome. So hopefully you can see my slides. Anyway, we'll work with that. Thank you again to Cara. I know you guys are in for a treat. I've seen Cara present on these medications previously for some of our GPAT doctors, and it was really, really helpful. And I'm really looking forward to her her slides a little bit later on. I just wanted to get in here and kind of give you a little bit of an update on some of the basic sort of overview of these meds and how you can access them, either through the National Medical Stockpile or through the PBS. So the first sort of question that is to get straight in your mind is we've basically got 3 medications available, specific COVID antiviral medications available for people with COVID in South Australia. First up, and our first preference, is Paxlovid, an oral antiviral, which has its own complicating factors with lots of medication interactions and a lot of contraindications. We also have Remdesivir available, which is an intravenous infusion over 3 doses over 3 days, which has previously been used for hospitalised COVID patients. And then we have the oral, the other oral antiviral, Molnupiravir, which, as Emily has mentioned, is available on the PBS through a streamlined authority process. Now, I'm wondering if maybe you can't see my slides all of a sudden. So let me try that. I'm hoping that's back. Hopefully someone can.
Yeah, that's great, Mel. I'm not sure if you want to press the slide, the presenter view as well. That might make them a bit bigger.
There we go. Better?
We're now seeing your, if you click on display settings, perhaps.
Yeah, let me just do a different share. I think this is the one we want. Hopefully that's better.
Yeah, that's great. Thanks, Mel.
Awesome. Sorry, guys. The joys of a couple of different screens. So we have the 3 main antiviral medications. We have in the past also used the monoclonal antibody infusions, Sotrovimab and Ronapreve. They're no longer part of the state guidelines due to their inactivity against the current variants and difficulty accessing them also. The other medication that you may come across and need to think about prescribing for patients is Vte Prophylaxis in pregnant patients who might have some risk factors for blood clots. That's usually done in conjunction with a discussion with their obstetric care providers. So just something to keep in the back of your mind, that we're no longer using the MABs, but we're using these antiviral medications. They seem to be far more effective. The other important thing to note is that Paxlovid and Remdesivir are far more effective than Molnupiravir. So before you kind of go and immediately prescribe Molnupiravir for all your patients in the community who may be eligible, it's really important that you stop and think about perhaps they're actually able to get or eligible or able to take Paxlovid instead, or Remdesivir might be an appropriate option for them via infusion through your local health network's COVID care centre. The important thing, as I said, is to think about the fact that we have 2 kind of ways of accessing these medications. First of all, we have the National Medical Stockpile supplied through the Commonwealth to the states, and that's how we've currently been accessing medications through the online referral form, and that's usually accessed through your local health network, who facilitate access to those medications through the COVID care centres. And that's where we've had very specific state guidelines around who is eligible, which is somewhat different to the eligibility criteria that have been set out for PBS authority prescription of Molnupiravir through community pharmacies, and the eligibility criteria under PBS for Paxlovid, which will be available from the 1st of May. So there's kind of these 2 different avenues. It's important to understand that if you're thinking about whether your patient might be eligible for a National Medical Stockpile medication, and at the moment that includes Paxlovid, they have to basically either be immunocompromised or if they're not fully vaccinated, they also have to have some risk factors. There's some very strict definitions of what constitutes immunocompromise, and that's available via the website, the SA Health website, where you can do your online referral. There's a document that clearly outlines all the different medications and conditions that qualify as being immunocompromised, which is quite a bit stricter than what you might normally think of. So just having diabetes doesn't make you immunocompromised enough. Having had a splenectomy doesn't make you immunocompromised enough. It's really looking at quite significant lack of immune response. It's important to note that when we consider whether someone is not fully vaccinated, we're talking about also people who might be overdue for their booster vaccine, or if they've only just had their booster within the last 7 days, so it hasn't had a chance to have a full effect, or anyone who's in less than 14 days since their second dose. So it's not just people who've only had one dose of vaccine or haven't had any doses. It's those kind of edge cases where they're probably not getting the full effect of a full primary course plus a booster. There's also quite strict definition of what the risk factors are for severe disease. So again, that information is linked in a very specific document linked on the front page of that online referral form. So you can have a check of that to get an understanding of whether your patient is likely to be eligible through the online referral pathway. And obviously Molnupiravir and Paxlovid have their own specific criteria as per the PBS. The current PBS criteria for Molnupiravir mean that if you have to be sort of over 65, or I think it's over 50 if you're Aboriginal or Torres Strait Islander, plus have various risk factors that, again, fairly specific in how that's outlined, and Paxlovid is quite similar. I'll send these slides around afterwards, and they link directly to those PBS criteria as currently outlined. The important thing to note is that there's kind of a Venn diagram of where people fit in terms of eligibility. There's a large overlap of people who will be eligible under either PBS or NMS criteria, but they're not exactly the same. So even if your patient may not be able to access the medication in one way, you may be able to access it through the other pathway. And generally, as I know you're probably all aware, you can, if you're trying to refer someone through for consideration for Paxlovid at the moment through the NMS pathway, through the LHNs, you can do the centralised online referral process. And it's really important to understand that referral for those medications is really time critical. The oral antivirals need to commence within 5 days of symptom onset, and that's where we consider the first day of symptoms being day 0. So within that first 5 days, remdesivir can be given within the first 7 days. So if there's someone who is at high risk and perhaps at day 6, it's still worth referring them through to see if they can access IV infusion of remdesivir. And I just wanted to sort of put a few thoughts out there. This is some of the things I've done with some of my patients in practice, because obviously this is a relatively complicated process, particularly when you're assessing someone who might have a lot of comorbidities as to whether they're eligible and whether it's appropriate for them to have particularly Paxlovid with all its many, many interactions. I think it's worth considering if you're doing GP management plans for chronic disease now, it's worth considering for your patients as part of that. Part of that planning might be, would this patient be eligible for antiviral medication if they were to test positive for COVID? And if so, what would my plan be? You know, would it be that their medications would be okay for them to have Paxlovid, or is that never going to be an option for them? Maybe we need to consider Molnupiravir. It's also something you can think about. I know I've had patients coming in, starting to come in for their winter dose, for their 4th dose of COVID vaccine. And it's good to have that discussion with them at that point that, okay, if you do end up testing positive for COVID, get in touch because I've identified that you are immunocompromised or you've got these risk factors that mean you might need to have some medication. Some practices have also done some proactive outreach for patients who are on immunosuppressant medications. And certainly some of the subspecialty clinics in the hospitals have done this particularly, where they've actually contacted all their patients who they know are immunosuppressed to say, look, if you do test positive for COVID, you need to get in touch ASAP and we'll help you access medication as needed. It's also worthwhile asking all your patients that if they are going to go to a mass testing site, can they ask for their COVID test result to be copied to you? I know I've done this. I know we're all frustrated by the fact that we often don't know that our patients have tested positive for COVID until several days down the track. So I think if we can all start trying to encourage people when they go through Victoria Park or through the Repad or Bedford Park or wherever they're going, can they say, as they're doing the sign up, can you please copy this to my GP? This is the name of their practice. This is the name of my doctor. And then they can actually get those results copied through to you. The other thing to consider is that if you've got at-risk patients who you think might be eligible to have Paxlovid or Remdesivir, think about if they have a recent EGF pharmacy, because that may come in quite important in terms of their dosing. So they're just a few kind of ideas and things we can do to start kind of try and get on the front foot with some of our patients going forward. And I just wanted to flash up a screenshot of my favourite webpage, and I'm sure it's everyone else's favourite too, the COVID-19 Mild Illness Treatment and Referrals page, where all of these documents are linked and where you can find the online referral form for accessing medication through the LHNs. Keep that bookmarked in your webpage and have it up when you're doing consults with these patients. It's really helpful. And in particular, this section on the outpatient guidelines for COVID-19 medication. So they were recently updated late last week. And I think it's really important to get familiar with those. And Cara obviously will be speaking more about the medications in detail in just a minute. That was really all I had to say from my point of view. I hope that's helpful. Obviously, anyone who has any questions, particularly specific clinical questions that you need answered in a not so immediate manner, feel free to email through to health.coviddoctorinfo@sa.gov.au and we will get back to you. Thank you. And over to you, Cara.
Thanks, Mel. Hi, everyone. Thank you for having me here. I will share my screen and hopefully be able to get these slides to work. All right. So can everyone see the screen moving?
Fabulous. Yes, it moves.
Perfect. All right, so you're going to be stuck with me for a little bit, unfortunately. So apologies in advance, but I'm talking about both Paxlovid and Molnupiravir from the sort of pharmacy side of things. And like Emily and Melanie have said, I'm Cara. I'm a COVID care centre pharmacist here at Carlin or Central Adelaide, and I've been working in the COVID space for 5 months now. It's felt like a lot longer, but we're getting there. So the first up is Paxlovid. This is the meaty one out of the two. I always start my presentations off with a disclaimer. The information I present to you about Paxlovid and Molnupiravir today is accurate today. One thing I've learnt over the last few months is that it changes rapidly. I'm talking week to week, day to day sometimes, even hour to hour. So please check your resources regularly, keep up to date and in touch with us. You can always ask us for clarification. And like I said, the information I present tonight is accurate tonight. So what is Paxlovid? Paxlovid is nirmatrelvir boosted with ritonavir, and I have a picture of the Australian supply up in the right corner here. If you Google image it, you come up with different boxes. So this is what Australia has, and South Australia specifically. That's exactly what it looks like. Nirmatrelvir is the actual active antiviral against COVID-19 or SARS-CoV-2. And it's a protease inhibitor, so it blocks that protease enzyme needed for viral replication. The virus can't replicate. There's a lower total viral load, which means reduced symptoms and reduced risk of disease progression. So that's how the nirmatrelvir works. Unfortunately, nirmatrelvir is eliminated extremely quickly. I'm talking 1 to 2 hours. So it needs to be boosted with ritonavir to help maintain those therapeutic plasma concentrations. Ritonavir is obviously just the booster. It doesn't have any antiviral activity against COVID. But the nirmatrelvir will not be effective if it's given without the ritonavir. And if you've ever worked in the HIV or infectious diseases space, you would have seen this combination before with drugs like Kaletra for HIV boosted medicines. So administering Paxlovid helps to prevent the COVID infection from worsening as less virus is able to replicate. And for those who are interested in the trials, the EPIC-HR and the EPIC-SR trials are the ones that were done on Paxlovid. They were the pilot trials, the first ones done, and where all of our evidence is taken from. The HR stands for high risk and SR is standard risk. The high risk or the HR study is where we extrapolate most of our data because this is the one that showed the most benefit. And I will say the caveat to these studies is that the patients in the trial were mostly, if not all, unvaccinated. But basically, the higher the risk the patient is of deteriorating, the better the benefit of using Paxlovid. So that's where that data is coming from. The appearance, so this photo is again the Australian and South Australian specific stock we have. This is exactly what those tablets look like when a patient pops them out of the blister strip. And you can see there's 2 pink tablets and a white tablet here. And I want to stress this, Paxlovid is a combination product. They don't take them separately, you have to take them together. Each Paxlovid box contains 30 tablets in total, 20 of the nirmatrelvir and 10 of the ritonavir. The nirmatrelvir are the 2 pink ones and the ritonavir are the white ones. The 30 tablets, is the supply needed to complete the full 5-day course. And so those with renal impairment and who need a renally adjusted dose will need to have tablets removed or need to be informed that they will have tablets remaining. Here at the RA and all of the metro COVID care centres, we actually physically we cut out that extra 2 nirmatrelvir tablets per blister strip to help reduce the risk of confusion and a patient taking too high a dose, but that might not be possible in all areas. So just be aware that if you can't physically remove those extra tablets for a renally adjusted dose, you will have to say to the patient, you will have some tablets remaining. So the dose, as I said, there's 2 doses for Paxlovid. If eGFR is above 60 ml per minute, then it's 300 milligrams of nirmatrelvir and 100 milligrams of ritonavir, so 3 tablets total, 12 hourly for 5 days, and that's how you get your 30 tablets. If they have a reduced renal function, GFR of 30 to 60 ml or 30 to 59 ml, the nirmatrelvir component is the one that's renally cleared, and that's the one that's renally adjusted. So you go from 2 tablets down to 1 tablet or 150 milligrams, but the ritonavir stays the same, and it's still 12 hourly for 5 days, which is 20 tablets total. So it's the dose of the nirmatrelvir that changes, not the dosing frequency or the duration. All 3 tablets must be taken or given together or consecutively. If your patients can't swallow 3 tablets at once, it's absolutely fine to take 1 tablet after the other, as long as all 3 are taken. It can be taken with or without food, glass of water without, doesn't matter. It should be swallowed whole though. I've even gone back to the manufacturer to ask if we can, do we have any evidence to crush, break, whatever these tablets? Unfortunately, we don't, so it has to be swallowed whole. And to take, obviously, for the full 5 days, even if the symptoms start to resolve earlier, just like you would with any other antibiotic or antiviral. The adverse drug reactions, the most common from the pilot trials were the changes in taste or the metallic taste and diarrhea. And in all honesty, from my experience in COVID care centre, the one that patients call back the most about is this taste change. Some report it as metallic, some report it as bitter, some just say, I've got this unpleasant taste in my mouth the whole day. It's not just with food. It does go away after the 5 days, so we recommend patients push through it, but this is the one we notice that most people call us back about. And then just some other common side effects, vomiting, headache, some people get a bit of dizziness, GI upset. High blood pressure and aching muscles and muscle tenderness is another Paxlovid specific ADR. It's not related to exercise, it's not harmful. It could just be the COVID as well. It's very hard to distinguish the drug side effects from the COVID symptoms, but these are the most common side effects that were found in the pilot studies. The guidelines in place and treatment, this is always the hardest slide because this is the one that's changing the most rapidly. So there's 1 and 2, you've got the South Australian based COVID treatment guidelines, and I've hyperlinked that to the SA Health website there. I will say right now, there will be another change to this state guideline before or on May 1st to better fit with the PBS criteria, but there will still be differences, so just be aware of that. The one you download or look at today will be different in a few weeks' time. And 2 is obviously the PBS criteria, which will be in effect from May 1st. I want to reiterate what Mel said, that Paxlovid is first line for all mild COVID-19, and that's due to its retained activity and efficacy against all coronaviruses. So not just SARS-CoV-2, SARS-CoV-1 and all other coronaviruses we know of, and that includes the current BA2 Omicron subvariant. We only consider other mild COVID treatments, so remdesivir or molnupiravir, if there is a contraindication or if Paxlovid is inappropriate to use. I've also just hyperlinked the national guideline risk stratification tool. It goes through, it adds on to what Melanie was saying about there's a very specific criteria about who qualifies for treatment. So this is just a nice visual example of that there. Who can have Paxlovid? This will be another sort of area that it depends on where you look. So the indication for Paxlovid, it's only for mild COVID-19 disease in the SA guidelines. And that means, things like no supplemental oxygen requirement. The PBS will say they can't be hospitalized, but obviously if we have a patient in hospital with a broken hip, they just happen to have mild COVID, they will still qualify based on the SA guidelines. So that's where some of the differences will come in. But basically it's for mild COVID disease. If they are sicker than mild disease, they require oxygen, then they don't qualify for Paxlovid, they need escalated therapy. Eligibility, as we've already touched on, there will be PBS criteria versus state guideline criteria, but basically it'll be based on things like day of disease, vaccination status, if they're immunosuppressed or not, and risk factors for severe illness. How to access right now is basically only via hospital pharmacies, as it's an NMS stockpile medicine. After May 1st, theoretically, it'll be available in community pharmacies. In the Q&A, I saw some really good points about not all pharmacies may order this in. It might take a day or so to order in. It is a high cost medicine, so more and more pharmacies will stock it, but on May 1st, community pharmacies might not have it right on that day dot. And pathways for access, again, inpatient, if they're hospitalised for something else, but they've still got mild disease, CCCs, or infusion centres via referral, GPAT via CCC, which is a branch off of CCC, and community pharmacies, which is upcoming. This is the sort of thing I want everyone to take home if you take anything at all from my presentation, is checking the safety and appropriateness. There are a lot of contraindications and precautions, so that's why I've listed them really nicely here and on the next slide, so it's easy to refer to. Basically, if it's greater than 5 days of symptom onset, they're allergic to the medicines or the excipients, they're less than 18 years old, pregnant or breastfeeding. Now, I've got no data there, so that could change in the future. And that is different to Molnupiravir, but I'll go through that when we get to it. Severe renal impairment, and that's GFR less than 30 mils per minute. I will say now, obviously we prefer as clinicians to use Cockcroft-Gault where we can. It's a slightly more accurate estimate of renal function. Unfortunately, the trials only use GFR. So by the letter of the law, I have to say you have to do a GFR. If you've got a 35 kilo, 85-year-old woman in front of you, we know that GFR is going to overestimate her renal function. So that might be more appropriate to use Cockcroft-Gault or creatinine clearance in that situation. But that's why you'll see GFR everywhere and not creatinine clearance or Cockcroft-Gault. Severe liver disease, Child-Pugh class C, the inability to swallow tablets whole, that's a big one for a lot of people, and drug interactions is the other one that's a really big risk factor for a lot of our patients. And that includes not just prescription, over-the-counter, complementary herbal medicines, and illicit medicines as well. These are the Paxlovid precautions as opposed to contraindications. So if you've got someone who you think has really reduced or unpredictable oral absorption, Paxlovid is an oral medicine. They've got GI resections, gastric bypass, masses, tumours, severe Crohn's flares, really bad diarrhea. The oral options, oral agents might not be appropriate for them based purely on absorption. Cognitive impairment or inability to manage Paxlovid regime. It's 3 tablets twice a day for 5 days. That is quite difficult for some people. Or conversely, I've had some people who would not be able to manage the changes to the other meds we would need to make due to the drug interaction. So that's something else to consider. And also for more of our regional rural patients, some people might not be able to store the Paxlovid less than 25 degrees. It's freezing today as I say this in a jumper, but there are some areas that are always above that temperature. Going a bit further into safety and appropriateness, very, very quickly, you're not going to have many patients with HIV that this will be an issue, but if you do and work in that area specifically, there is obviously the risk of cross-resistance using ritonavir and Paxlovid to ritonavir or HIV medicines, especially with the protease inhibitors. With pregnancy and breastfeeding, Paxlovid is currently not recommended during any stage of pregnancy or breastfeeding. Breastfeeding should be stopped for 12 days total, or we use a different agent. Women on hormonal contraception, so like the pill, need to also use additional barrier contraception for a full menstrual cycle or month after completing the Paxlovid in addition to their hormonal contraception, just because that ritonavir will potentially affect the efficacy of the pill. As I've already said, there's standard dosing GFR above 60, and there's the renally reduced dose if they're 30 to 59 or 30 to 60 ml per minute, and it's not recommended in a GFR of less than 30 ml per minute, and that includes patients on dialysis. And that is something that's different to, say, remdesivir, where you can't use it unless a GFR less than 30, but you can use it in patients who are on hemodialysis. So less than 30 ml per minute or on dialysis, can't have Paxlovid. And hepatic, again, it's the ritonavir component we're looking out for this time, as opposed to an renal impairment, not recommended in Child-Pugh Class C. This is the really, really meaty bit, the drug-drug interactions. There are many, hundreds and thousands of drug interactions with this medication, this combination product. Nirmatrelvir is obviously the CYP3A4 substrate, so any CYP3A4 inducers could result in treatment failure because it's clearing the nirmatrelvir faster, whereas if you have any 3A4 substrates additionally, other drugs, the ritonavir will increase the drug concentrations and potentially the risk of toxicity. And really importantly, it takes our bodies at least 3 days to get rid of ritonavir, to clear it. So the drug interactions persist for 3 days after the course finishes. So we recommend holding or adjusting doses of interacting medicines for at least 8 days. So we usually say go back to normal on day 9. I always recommend checking multiple resources for drug interactions with Paxlovid. The first line I always recommend is the University of Liverpool COVID drug interaction checker. This is specifically developed for the COVID-19 drugs, and you may have used it already for HIV or Hep C drug interactions. The only downside is that the University of Liverpool one, the drugs it takes from, I think it's the World Health Organization essential medicines list. So there are quite a few medicines that are not on there that you can compare it to. So if you find a medicine that's not listed on that one, I always recommend then going to a second drug interaction checker. I like personally using UpToDate because it's an American database, so it's got a lot more drugs. Stockley's is obviously pulling from UK and European data, so it's got a different set of drugs to pull from there. I will say Stockley's is a bit more conservative in its recommendations, but again, that's just differences between drug interaction checkers. And if you're really unlucky and been in a situation like I have, where you have someone on a drug that's not in any drug interaction checker, that's when you go back to, the product information, MIMS, first principles of drug metabolism, and go, okay, what am I expecting to happen to this drug if I give them ritonavir? And just like I said, just because a medicine's not listed, it doesn't mean it doesn't interact. We have a blanket rule here in Carlin and the metro areas with complementary and over-the-counter, supplements, herbal things, to hold everything for 8 days. It's just a bit easier. The herbal supplements, there's obviously the risk of PK, so CYP interactions, whereas the minerals like iron, zinc, calcium, there's the possibility of pharmacodynamic, so like chelating and absorption reduction interactions. And just be aware of illicit medicine interactions as well. Ritonavir will increase the exposure of THC, opioids, amphetamines. So there is the risk of toxicity. So yeah, just be really careful with that. This is just a screenshot of what the University of Liverpool drug interaction checker looks like. If you haven't seen it before, you can literally just Google that and it'll come up. It's free to use. It's really user-friendly, easy. You can see, you just type in your COVID drug, what other medicines they're on, and it'll come up with the results here. And this is just clicked into what some of those results say. So if you have a red box interaction, it says do not co-administer. So carbamazepine is a classic example. Potential interactions, the statins, CCBs, things like that, they often come up here, and the no interaction expected will be the green. So that's the sort of traffic light system they use. If you click into any of the more informations, it has the Liverpool interaction checker has really good detailed information, and it gives you the rationale for it, what we expect to happen. So if you do need to continue or adjust something, it will give you advice on that. And I just wanted to pull up an example of a green medicine that doesn't theoretically interact. There are some that have exposures increased or decreased by, over 50%. And in some patients that might be clinically significant. So just don't assume because it's green, you don't have to do anything. In most of the cases, it is fine, but there are some cases like propranolol exposure increases by over 50%. So if someone had a low heart rate already, I might be adjusting that dose, even though it is a green indication, green box interaction. This is another sort of traffic light system. And if you ever hear red box drug interactions, this is what we're referring to. This is in the state guidelines that are available on the SA Health website. basically, if you've got someone on one of these medicines, they can't have Paxlovid. There are some exceptional circumstances. Lecanidipine, you can usually stop for 8 days without any issue. Colchicine, if they're only taking it PRN for gout flares, you can usually stop it with and give Paxlovid without any issue. Things like clozapine, the antiepileptics, the anticoagulants, things like that, the antipsychotics, you can't get around it. They can't have Paxlovid, but that's all available on the SA Health website. So now the consenting process. So consenting is necessary for Paxlovid and Molnupiravir and Remdesivir because it's a new novel medicine. It's only provisionally approved by the TGA, and that was to facilitate its immediate use in Australia. There's limited evidence on both its short and long-term side effects. So verbal or written consent is always needed before we give the drug. I've got some hyperlinks of example written consent there. Verbal consent is much easier if you have that conversation in person or over the phone with them. As long as you document it clearly in the patient's notes or medical records, then that's enough. And just to remind everyone, a patient can obviously refuse treatment or withdraw consent at any time. And we've had that quite often with patients calling us or coming into the centre and going, actually, I changed my mind, I don't want to have it, or vice versa, calling us back saying, I've thought about it and now I want it. Now the counselling process. So the counselling process from a pharmacist point of view, from my pharmacy brand, counselling is explaining to the patient what the drug is, how to use it, why are we using it, what are the potential risks and benefits, the dose, frequency, duration, what side effects can they expect, and what do they do if they get really bad side effects or if their COVID symptoms worsen. You can also throw in discussion about, vaccinations and things in here too. I often do that with my patients in CCC, but obviously every patient is different. The SA Health website has the consumer information sheets, as do the TGA and MIMS. It'll take you through what you need to say in a logical order. So if ever in doubt, you can always run through those. And always remember to avoid using medical jargon. I've had people trying to explain the study percentages and this reduces that by this much, and they're not going to remember that. Most patients need the bare bones. I have put a brief slide in here about vaccinations. The general rule, like with any acute severe illness or acute mild illness even, we don't usually recommend giving vaccinations while they're acutely unwell. This is the same for COVID-19. Patients have a variable recovery. So I usually say if you're feeling better and you've discussed it with your doctor, well, then we're happy for you to get your COVID booster or something like influenza vaccine. Influenza vaccine can be given on the same day as a COVID vaccine. That's absolutely fine, but it still can be delayed if the patient prefers. And depending on the patient's severity of disease, the medicine they received for COVID treatment, and how long they take to recover, it will depend on when they qualify for their next COVID dose. But I've linked COVID vaccine, sorry. The ATAGI website, I have hyperlinked there. There will probably be an update again about the winter booster for more of the population too. So have a look at the ATAGI website pretty regularly. These are just examples of the consumer health information sheets. The SA Health one is on the left, the TGA one is on the right. Hyperlink them there for you. There's no right or wrong. You can give one of, you can give both. As long as the patient gets some written information, that's all that matters. This is again a close-up of what the front of the Paxlovid box looks like. All of the boxes are printed automatically with this over here on the left. So if you have someone on a renally adjusted dose, your pharmacist or yourself will have to manually adjust this to say 2. The drug company didn't give us these stickers, unfortunately, so you have to make your own. But so just remembering that you have to physically alter the packet if someone has a renally adjusted dose, because otherwise it'll say the wrong instructions. And exactly like Melanie said with that lovely Venn diagram, different guidelines say different things. The PBS compared to SA Health guidelines compared to national guidelines all have slightly different recommendations for mild COVID. It's very frustrating. We are working on some table visual summary to sort of explain all of that, but we'll probably get that out once it's on the PBS and dust is settled ever so slightly. But I've just put a very quick and brief summary of some of those changes between the PBS to SA Health to national guidelines there, and they're all hyperlinked as well. Wherever possible, try to use the SA-based recommendations. They tend to include more patients. The PBS criteria is quite restrictive for some people. And the SA guidelines also take into consideration things like stock issues and local variant data, which the national guidelines don't. So obviously, a lot of us will have to do PBS prescribing, but if you have someone who you still think might qualify based on SA guidelines, that's when you'd refer them into a CCC to get them on the non-PBS pathway. And this is, again, available on the SA Health website. This is just the guidelines as they are right now. And you can see the first line's Paxlovid, second line Remdesivir, and second/third line is Molnupiravir as well. Now, would you like me to answer the Paxlovid questions now, or do you want me to power through Molnupiravir and then we'll do all the questions at the end?
Oh, I must say, Cara, this has been a fabulous presentation. I mean, you make things so much clearer. So thank you.
Oh, thank you.
No doubt. This is no doubt very overwhelming, a lot of this, because it is really quite complex. It's not easy, and we know that this is going to be a big shift come 1st of May when we start prescribing Paxlovid. Look, we have had a couple of questions. One was around the EGFR, particularly, if you do have a patient and you're not quite sure, they might be perhaps in their early 80s, you're looking at using Paxlovid for them, should you then hold off and do the EGFR and wait and see? That's been something we should consider. What would you suggest in that case?
So I obviously, based on my clinical experience as a clinician, I'm not a doctor, but as my pharmacy experience, we know that GFR fluctuates quite a bit from day to day, and we know that this is a short course, it's 5 days. I am very comfortable, and I know a lot of my colleagues, both medical and pharmacy, are very comfortable starting at the normal, not renally adjusted dose, and then also taking bloods. And if we find they've got really reduced renal function, we can always call them up and say, actually, I know you took 3 tablets twice a day yesterday, but can you only take 2 tablets twice a day from now on? The effects from an extra day or 2 of the increased dose in someone with, moderately impaired renal function is not going to be that significant in the grand scheme of things. I'd rather they get the drug in earlier than have to wait an extra day or so to get started because we're waiting on bloods. But it's a very good question.
Oh, that's perfect. You've made that very clear. Thank you. The other question was going to be around vaccination, but you covered it, which was fabulous.
Oh, good.
Around,
yes.
Can you receive a vaccine? Of course, we've got that 90-day period with Sotrovimab. Can you then give the vaccine once someone's recovered? But you've answered that already.
That's right.
So thank you.
Thanks. It's much easier with the antivirals, and that there's not that 90-day wait like there was for the monoclonals. It's a bit easier in that respect.
No, that's fabulous. Let's cover the key questions that we had come through. So I think let's move on now to Molnupiravir, and please encouraging everyone to post questions if you have them in the Q&A. Mel and I are both working our way through those, and of course, it'd be great to be able to ask specific questions and get Cara's expert knowledge. So thanks.
Thank you. All right. Hopefully, has that pink screen? It's very pink on my screen at the moment.
Yes, no, it's perfect. That's great. We're
Excellent.
differentiating.
I know, I have to colour code the drugs. Molnupiravir is pink, Paxlovid is blue, and Remdesivir is purple in my mind. So that's how they're all colour coded. So unfortunately, that's how it's colour coded for everyone now. Again, we're going to speed run this because a lot of it is quite similar. My disclaimer, it's current as of now. So Lagevrio. Lagevrio is the brand name. Molnupiravir is obviously the active drug ingredient. And again, I've got the actual Australian and South Australian stock image here. So this is what it looks like. Don't trust Google Images if you see something else. Molnupiravir is again an antiviral. And this is slightly different. It's not quite a protease inhibitor. It's a prodrug that's metabolized basically into a ribonucleoside analog. And that's incorporated into the viral RNA. So it basically creates that fault and that error. And once there are enough accumulations of those errors and those faults, the virus can't replicate, and that's how it lowers the viral load. So slightly different mechanisms, but the same end outcome. Again, administering Lagevrio or Molnupiravir can help prevent the COVID-19 infection from worsening as less virus is able to replicate. However, as we've already said, Molnupiravir is less effective and less efficacious or advantageous compared to Paxlovid. So that's why Paxlovid is first line. It's got a higher risk reduction. It's more likely to keep people out of hospital and prevent severe deterioration, whereas Molnupiravir still has some benefit, but that benefit is nowhere near as strong as for Paxlovid or Remdesivir. So I do want to stress that. And those, again, who like looking at the trial data, it's the move out trial. It was phase 3 when Molnupiravir was first approved in Australia, but I'm assuming it's been finalised now. I haven't actually gone back and checked. But again, it was done in mostly unvaccinated outpatients. The higher risk patients had the most benefit, but you can see the benefit, risk reduction of hospitalisation is less than that compared to Paxlovid. The appearance, this is the little capsules. There are 40 of these little ones in the bottle, and the 40 capsules is the supply to equal exactly 5 days. And there should be no capsules remaining, and there's no dosing adjustment, so it should be the full bottle finished. It's called Swedish orange, but it's sort of more like a reddy brown in all honesty if you see it in real life. So yeah, I don't know why they called it that. They're probably about the size of a pregabalin 150. Definitely smaller than a pregabalin 300 milligram. Those are quite big capsules. And I forgot to mention, but Paxlovid's about the size of a pantoprazole 40, maybe a touch bigger, smaller than a pregabalin 150. So just for size reference, if you're trying to assess if someone can swallow them. Molnupiravir is 800 milligrams or 4 capsules, 12 hourly for 5 days. So yes, it's 8 capsules a day for 5 days. All 4 capsules again must be taken or given together or one after the other consecutively. It can again be given with or without food, with a glass of water, breakfast and dinner, breakfast and bed, 7 a.m, 7 p.m, whatever suits the patient. If you read the product information, MIMS, a lot of the guidelines, the national guidelines or some of the older documents, it will still say they need to be swallowed whole. And I've put big asterisks there for a reason. We'll go on to it on the next slide. But again, take for the full 5 days, even if the patient starts to feel better before the course finishes. So as I said, if you look at certain resources, it will still say you cannot modify the dose, so you have to swallow these capsules whole. However, the manufacturer did give us some information to say that we can actually open the capsules and we can disperse those capsules in water or in food. So those who cannot swallow, this is an option, and it's the same for NGTs, nets, pegs, things like that. The dosing instruction, dose modification instructions, all the pharmacists, Metro and Regional, have a copy of this. It's also in the drug monograph, an abbreviated version on the SA Health website, but if you would like the full copy, please let me know and we can send that out, but it is quite a long document. So the drug monograph simplifies it quite a lot. Adverse drug reactions seem to be a lot better tolerated than Paxlovid. It could be that it's less effective, so maybe that's why, but yeah, mostly diarrhea, bit of nausea, GI upset, bit of dizziness. I haven't had many patients call back to ask about, is this a normal side effect with the Molnupiravir compared to the Paxlovid? So it does seem to be a bit better tolerated. Again, guidelines in place and treatment. This is changing. It'll probably change again once Paxlovid's on the PBS and that state guideline change happens. This will change less than Paxlovid in that it'll always be sort of the last line option, just again, because it's the least efficacious. We want people to have Paxlovid or Remdesivir first. It's only if they can't have either of those two that would be going to Molnupiravir. So who can have it? Again, same indications, mild COVID-19 disease. So usually that means just no supplemental oxygen requirement or no increase in baseline supplemental oxygen requirement. PBS criteria, which is already active, that was from March 1st, or again, the SA Health guideline criteria. And again, there are differences. Very annoying, but unfortunately that's the case. How to access Molnupiravir. So on the PBS via community pharmacies. So what we've been doing since March 1st, via COVID care centres or infusion centres or hospital pharmacies if a patient doesn't meet the PBS criteria but still meets the SA guideline criteria. And the third option, which is unique to Molnupiravir, is via residential care facilities. So the Commonwealth had 2 streams for delivering Molnupiravir. They sent it to us in the hospital pharmacies as the NMS stockpile, but they also sent a separate supply to almost every residential care facility or nursing home in the country. So most residential care facilities will have Molnupiravir stock on site, ready to go. So you don't need to do anything except confirm that the stock is there. And if the patient is appropriate for it, they can actually start it from that stockpile they have on site. So that's something not everyone might know about, but it's something unique to Molnupiravir. Pathways for access, again, inpatient, if they're hospitalised with something else, but they just happen to have mild COVID disease, absolutely can still get Molnupiravir. CCC via referral, GPAT via CCC, and community pharmacies, which again has been in place since March the 1st. There are a lot less contraindications to Molnupiravir, but some of the same ones are if it's greater than 5 days since symptom onset, they don't qualify. If they have an allergy to the drug or its excipients, less than 18 years old. Now, this you will notice is different to the Paxlovid. The pilot trials and animal studies showed potential bone or cartilage effects in children and teenagers or younger adults. Compared to with Paxlovid, there was just no data. So this is something if we were expecting one of the drugs to be reduced down to 12 years of age, it would be Paxlovid, not Molnupiravir. I don't think it'll go below 18 years of age as the recommended minimum. And the same thing with pregnancy and breastfeeding. In America, Paxlovid has actually already been approved for use in pregnancy and breastfeeding, and it's not unexpected. We've used ritonavir and HIV medicines with ritonavir in pregnant and breastfeeding women for many years. So that has just sort of been extrapolated to Paxlovid. However, with Molnupiravir, pregnancy and breastfeeding, the animal trials again showed some teratogenic or mutagenic effects. So that's something I don't expect to change either. So I just wanted to specify the differences between those there. The precautions, again, very similar, essentially the same for Paxlovid: reduced oral absorption, cognitive impairment, unable to manage the 8 capsules a day, or unable to store the medicines appropriately. Furthermore, checking the safety and appropriateness, drug interactions. This is the good news with Molnupiravir. It's not expected to have any drug interactions. It's not cleared by SIP, PGP, or renally, so essentially no drug interactions. As I said, with pregnancy or breastfeeding, Molnupiravir is not recommended in either. If they are happy to interrupt breastfeeding to have Molnupiravir, they have to stop breastfeeding for 9 days. So 5 days course and 4 days after. Obviously not for pregnant women. And the big issue we will be having is young men. So men who are sexually active with a partner who can become pregnant have to use effective contraception, so barrier protection, for the duration of the treatment, so 5 days, and for an additional 3 months after the last dose of Molnupiravir. So you are going to have to ask young men to either abstain or use barrier protection for 3 months if they use Molnupiravir because of those suspected mutagenic and teratogenic effects. And again, similar to why there's no drug interactions, we don't have to adjust for renal or hepatic impairment. So this can be used right down to, really severe liver or renal disease. Consent, exactly the same as I said about Paxlovid. Make sure we have that discussion, the risks and the benefits. This is what we know. If they consent, we need to document it clearly. Counselling, again, exactly the same. What is it? Why are we using it? What are the risks and benefits? How do I take it? What side effects can I expect? What do I do if I feel worse? Basically, that's it. And again, the vaccinations, the same as Paxlovid in terms of there's no delayed vaccination period like there were with the monoclonals. As soon as the patient feels better and stops the course, they can technically get their booster. And this is just the example of the Molnupiravir SA Health consumer information sheets versus the TGA ones. But again, they're all available through the same parts of the SA Health and TGA websites. And again, this slide is slightly different to the Paxlovid one. So if you screenshot that one, I recommend also screenshotting this one. And the hyperlinks are slightly different too. But yeah, again, the PBS, you need multiple risk factors. So it's age plus 2 others. Those who are, unvaccinated, who are less than 65 years old or 50, if they're at sea, will not qualify for treatment, as opposed to the SI guidelines will allow those people to qualify for treatment. SA Health doesn't have any of the monoclonals like sotrovimab or Molnupiravir or the inhaled options on their guidelines, but if you check the national ones, they do. And then there's the whole Evusheld thing, which is a whole nother kettle of fish. So again, different guidelines say different things. If you're unsure, always check and try to stick to the SA ones where possible. I acknowledge, obviously, though, that a lot of your prescribing will be PBS based, but there is the pathway to refer to us at a CCC if you think someone doesn't qualify on the PBS, but they should still qualify on the state guidelines. And this is just a comparison of the state guidelines on the left to the PBS requirements on the right for Molnupiravir specifically. The PBS criteria for Molnupiravir should be exactly the same for Paxlovid. I think the last update I read was that they weren't going to change or add anything. Another big thing is we only found out yesterday the PBS sort of risk factors and categories. It doesn't say anything about ischemic heart disease or cardiovascular disease. It only has congestive heart failure, whereas SA Health, we class that as a risk factor. So there are just some of the differences there. All right, I told you that last one would be a bit quicker. Molnupiravir is much easier to talk about. So yes, I'm happy to take any questions about either medicine.
Oh, thank you, Cara. Again, really great presentation. I mean, you've opened the door now. I can't say it correctly, Evishield, and I've said it probably wrong, but no doubt that's going to become more and more topical as we move forward, particularly where we see cases in residential aged care and in disability as well, particularly in the last week or so. We've had a couple of questions come in, and I'm so pleased you did discuss around the contraception for men, and this will be a factor absolutely to make sure that we're properly counselling in this space. There was a question that came through around if someone does have a regular female partner and they're on a long-acting contraceptive such as a Mirena, is it reasonable then to avoid condoms in those particular, or protection in those particular cases for the men?
My legal answer is no for this recording. Look, no contraception is 100% effective. There is still the risk that even someone who's on a Mirena or a copper IUD could still become pregnant. So based on the man potentially the sperm being altered and changed and causing changes to the fetus, that's why we recommend barrier protection. Obviously that risk is very low with the Mirena. I'd say use your clinical discretion and decision making in that, just letting the patients know, both the female partner and the male taking the Molnupiravir. I don't think it's unreasonable. I just have to say that not all contraception is not 100% effective. So I hope that's a very politician answer. No, I do apologise.
No, that's very helpful. Look, it really should just be that standard advice, no matter what, especially with some of these newer medications. And no doubt there'll be more data as well that will come out over time around the use of these medications. The other question is more so specifically related to aged care, and I thought I would just bring up around the residential aged care facilities. And for those of you who are not aware, listening in online today, that we do have quite significant supplies of Molnupiravir in the aged care facilities. And the Commonwealth did a big drop off into the aged care and also into the Aboriginal community controlled organisations. I don't know, Cara, are you getting many people calling in for advice around these medications, or are you seeing much usage of them out in the community?
Yeah, so unfortunately, we're not seeing the uptake in the residential care facilities as high as we would like. They were dropped there for a reason, but admittingly, not a lot of education was done when they were first dropped off. So a lot of people went, what is this new drug on my doorstep? Completely understandable too. So we have had a lot of RCF GPs, nurse unit managers call us and go, hey, I've got this patient, what do you think? So we have been giving a lot of phone advice from our CCCs. And we have also had a lot of patients transferred into hospital, either ourselves or ED, saying they need this treatment. And we go, no, actually, they qualify for Molnupiravir. Do you have some at your site? Yes, yep, they can go back and start the treatment there. So it has been a slower uptake than we initially thought. It's not to anyone's fault. It's new drugs, new processes. But we've worked really hard the last couple of weeks to sort of get that information out there. And I know I've sent out some information to Melanie and Jenny Gould and everyone to sort of disseminate that Molnupiravir is available at residential care facilities. And we do have a lot more community pharmacies stocking it as well for those PBS patients.
Yeah, and we had a question just come through now around just to the panelist group. So I will say this, it's not in the Q&A, around patients not being eligible in aged care facilities, and this was in response to not having the risk factors or being immunised. And of course, most aged care residents are now immunised because there was such a strong push with the program. I guess that's something. I mean, I was thinking about this when you said there's a difference between the PBS and the SA Health guidelines. Do you think this is going to be a bit of a gap as we move forward, potentially, that we'll see more referrals coming into our COVID care centres because of the guidelines?
100%. Everyone keeps saying, oh, once they're both on the PBS, all our problems will be solved. It will help a lot. It will not solve all our issues, and there will still be that gap between what the PBS say versus what our guidelines say. And also we've had doctors go, well, this is in the national guidelines, why can't I give that patient this. And it's like, well, that doesn't match the PBS or our state guidelines. So it's very, very difficult. Yeah, so you will have patients within those gaps, and that's when we recommend to refer in, because that's where we can sort of assess where they fit and see, you know, what option they can have. And the residential care facility, you know, residents, they don't have to necessarily meet PBS criteria. It doesn't have to be a PBS script, and that's when a call to CCC to say, hey, I know they don't meet PBS criteria, they're technically fully vaccinated, but they've got X, Y, and Z that would contraindicate them from this, or, you know, they've got an advanced care directive that they're not for escalation to hospital. Would Molnupiravir be appropriate? That's when we can have those discussions over the phone.
Yeah, that's a really good point. We do have that flexibility with the stockpile, that we can be somewhat flexible based on ID and pharmacy advice. So thank you. We had a question around storage of the medications in the fridge. What's the advice around the storage temperature for both these drugs?
Yeah, I've had patients, you know, levothyroxine and insulin, they keep their medicines in the fridge. You can definitely put it in the fridge. It's not going to, as long as it's not frozen. So if it's in the fridge, it's totally fine. Especially in those hotter areas, or if someone doesn't have electricity, or, you know, you need to keep it cooler. So yeah, in the fridge is totally fine. Not necessary.
Perfect,
though.
Thank you. No, that's really helpful. And we did have another question about the aged care facilities, or more so a comment as well, particularly over 75s in aged care facilities does qualify for Molnupiravir. And that's exactly right. If you look down in the risk factors, it does say over 75. So it's over 65, but then if you go down, you then move into the greater than 70. It's confusing, I agree.
It's so annoying. There are so many different ages, and it's a mess.
We have raised some of these concerns back to the Commonwealth. So just for everyone's awareness, we have had discussions around what is the future of these medications, because the National Evidence Task Force has set different recommendations to what the PBS have set. And then, of course, we have the state recommendations. So all three of them are somewhat slightly different at the moment. And so we did bring up with the Commonwealth around whether we would see an adjustment with Molnupiravir. So there is a big move now overseas that the cost of that medication will come down substantially because of the ability now for multiple companies to start producing it. And we do hope that we will, even though it is only sitting at that 35%, I think you said, Cara, we absolutely are really hopeful that we will see greater utilisation and uptake in the future around Molnupiravir, more widely utilised. I don't know if you had any comments about private scripts at all in this space. I mean, I'm certainly aware of a couple of people who have paid for a private script now of Molnupiravir who've been in the community and not met criteria. I don't know if that's come up at all.
They have a lot more free cash flow than I do if they can pay for it privately. Though, for those who don't know, Molnupiravir is just under $1,100. It's like $1,050 something a box. So for one course, it's $1,000. So those, without Medicare or who don't qualify and have a non-PBS prescription in the community, it will be over $1,000. And that's a lot of money for a lot of people. If you do have a patient that, again, is not in that PBS criteria, but you think will still qualify for it, again, legally, I can't say, just send them all to us and we'll give it to them for free. But if they do qualify and they are appropriate, we do have workarounds. If they're from a country, they might not have Medicare, but if they're from a country that has reciprocal Medicare, they can often access it for free. If they've got travel insurance, or overseas insurance, that will often cover it. So there are options for those people who might not qualify and might not have Medicare or something like that, but it's not a guarantee.
No, that's great. Thank you. And thank you for raising around the pathways as well. We've just had another question come through around the referral process or pathway for Paxlovid, and we have put out some information already around this, that at the moment here in SA, it is still through that online referral system through to the COVID care centres, but post 1st of May, we will see those changes come in. We did ask through the Pharmacy Guild around which pharmacies are going to be stocking the medications. It's all well and good saying 1st of May, that we're just not quite clear still. I don't know what advice you've got or you've heard anything in this space, Cara. We expect it'll be at least a few days post first when we see that roll out.
Yeah, do not expect community pharmacies to have this drag on the 1st of May. Do not. I have worked in community pharmacy. They're exceptional, but they are not that good. They can only order it at the PBS, subsidised cost and the protection once it's on the PBS. So they can't stockpile it the week before to go on the PBS, they'll have to pay full cost. So it's not economical for a pharmacy to order it in before the 1st. So there will be a delay. So if you have someone on the 1st of May, if by some miracle you have a pharmacy that has it in stock on the 1st of May, go for gold, but expect a day or two at least delay in that uptake, of putting the orders through, the distributor sending the stock out to all the pharmacies, and the pharmacies having it on site ready to give out to patients. So there will probably be a slight delay.
Yeah, no, and a good point. So please continue to refer your patients through the online system. Mel's just posted it into the Q&A as well, that web page there, which we are continuing to update with the guidelines out of Carlin, also our GP fact sheets as we produce those to make it really easy, because this is complex. This is not easy, working out A, if your patient's eligible, B, what are the contraindications, and C, how do you take it? But you've explained that exceptionally well, Cara. So we'll make sure that the key points are captured in our fact sheets. And if you do have suggestions and you think, oh, it'd be really great if we could, know what those references are, or where to look up drug interactions, we can send all of that out to people. We've had a request for your contact details, Cara, so we'll see what mechanism you would like us to provide people for the pharmacy service through Carlin or through the COVID care centre as well, if that's okay from your end.
That's fine, as long as it's my work number. Otherwise, I don't want to be woken up at 2 a.m. for this. No, I'm joking.
No, that's great. We did have one last question, and then we might leave it there if there's nothing else coming through in the Q&A, or if Mel's got anything else to add. And this was about, how do you simply explain the benefits of these drugs to patients other than saying they might reduce their risk? I think that's a really good question that's been posted. I mean, you mentioned, Cara, around how we don't want to overwhelm people with the stats around the percentages and the efficacy. It gets really, we've done it with the vaccines, and we've got ourselves into this space with that. Do you have any simple words or advice or tips that you've picked up of how we can say this simply to our patients?
Yeah, I've got a few. So some of the doctors, I've stolen this with pride. It won't necessarily make your COVID infection as it is better right now. It won't make what you're feeling get any better right now, but it will stop you from getting any worse. What I usually like to say is that, for example, Paxlovid, it's a combination medicine. The two drugs work together to help stop the COVID virus from growing in your body, from getting any bigger or worse. And that obviously means you're less likely to get sicker if there's less virus in you. That means you're less likely to get sicker and feel worse. It also means you're less likely to end up here in hospital at the Royal Adelaide getting treatment. That's my very layman's expression. I think I could say it in my sleep now. So that's usually what I say, but please, anything along those lines. Obviously, a lot of that isn't pharmacokinetically and anatomically correct, but it's what the patients seem to understand.
And I think we're now seeing this transition across, and we've talked a bit about GPAT, and we're very grateful for Jenny Gould and the GP assessment team who have picked up a number of these pharmacy risk assessments, essentially then to stratify out patients into the COVID care centres or back into the community treatment space. So a very big thank you to the GP assessment team just to help us get through the large volume. So if you refer your patients in, they absolutely are being assessed and being directed to the most appropriate place and appropriate medication. But I just wanted to point out on that point is that we're actually seeing now this shift away from people who are not eligible and are really fully vaccinated, triple vaccinated, maybe heading towards that fourth winter dose. The messaging around, well, do you have any advice, Cara, we can give for that messaging when they're not eligible, and really how to talk them out of it? That and this comes back to, I think, the cost. If people are thinking that they're going to really commit huge money to this, do you have any words of advice for those individuals, particularly if someone, it might be in the case of the 73-year-old person that we've had posted into the chat box?
Yeah, it's a really difficult conversation. I'm very lucky that I don't have to have that conversation, and the doctors and CCC have that particular conversation, and I don't envy them. It's really tough telling someone, look, you don't qualify for treatment. I've heard, Jackie Yo, Nicholas Faranola, a lot of our doctors here at COVID Care Centre are excellent, and they're much nicer at saying it, basically. So maybe ask them for exact quotes, but the national guideline I hyperlinked in both slides that has the risk stratification tool. It shows that if someone is fully vaccinated and is less than 65 years of age, there's a nice beautiful green bar that says low risk of progressing. So sometimes showing patients visually, like, based on your age, based on your vaccination status, based on your risk factors, you can see that you're actually in what we class the low risk of getting severe COVID. And it's also a tool you can use to help convince people to have treatment as well. If you've got someone who's unvaccinated, over 65 and multiple comorbidities, it's a nice red, this is the highest risk of, disease progression and deteriorating. So I recommend using that. Explaining that, we can offer you supportive care. We're not going to abandon you. I think a lot of it is not feeling like they have anywhere to contact. We still obviously offer, Carl and CCC, we're open 7 days. If you are worried or have questions, you can always call us, or giving them the option. If you think you are getting sicker, speak to your doctor, speak to your GP, your specialist. If you think you're really sick, you can always go to ED within reason, obviously, but it's just providing them not a blunt no, you don't get treatment. It's sort of giving that holistic approach of, you might not qualify for treatment, but this is what I can offer you for your symptom management here, and this is what you can do if you have questions or need further follow-up.
Yeah, very, very wise words. Thank you. No, very good. We've had so many great comments as well in the Q&A. Thanking you, Cara, for the presentation tonight. It's been really excellent,
Thanks,
really
everyone.
simplified. Some of this, because this is complicated, and so we'll make sure that people get a copy of your slides, and also this presentation has been recorded as well. So please encourage colleagues to reflect back on this. Before we end, I'm going to just hand over to Mel. Mel, did you have anything further you wanted to add, or tips or tricks you think we should share in the last couple of minutes?
Just to reiterate that obviously this is a fairly complex process, so any work you can pre-do for your patients, because they're probably all going to end up with COVID at some point. So any kind of preparation you can do as part of your normal consulting is probably going to help you down the track. So try and start thinking about these things in the course of your other consultations, and have that in mind. And if you can get it incorporated into your GP management plan, chronic disease planning, it'd probably be really helpful as well. And thanks again to Cara for putting so much rich information out there for us. It's really helpful, so thank you.
Wonderful. Thank you, Cara. No, and such great comments back. And I must say, Cara has already checked the hyperlinks, that they do work in the slides. So we'll make sure that those are sent out. We've had a question around the hyperlinks. There's nothing worse when you go and click and it's an invalid link on the SA Health website. So thank you so much to both Mel and Cara this evening for joining us. And a very big thank you to Adelaide PHN, to Brendan and Crystal again for hosting us at such short notice to help us put on this webinar. We were really conscious that we're so close now to the 1st of May, and many people are off on holidays, and we know it was very short notice to bring this together. So a big thank you to Brendan and Crystal from Adelaide PHN for this evening. All right, I'll leave it there from my perspective. Brendan, I'll hand back to you. Thank you.
Thanks, Emily. That was an amazing presentation, Cara. So thank you so much for that. And we'll be distributing this to the doctors who registered for this webinar. So stay tuned and we'll get all this information to you guys. Emily and Melanie, fantastic, absolutely amazing as always. So thanks again, and we look forward to the next one.
Wonderful. Thanks, everyone. And we hope everyone gets some time off this second long weekend in a row. All right, take care.